Well, Dr. Mesa, first of all, Happy New Year and
Happy New
Happy
Year.
New Challenge. What's happening? What's happening in North Carolina?
Well, I'm really excited to be starting going back and forth next week. This was a unique opportunity. I've been now at the Mays Cancer Center for almost 6 years, and it's been a phenomenal trajectory. It's a wonderful institution. We've grown funding, we've grown by membership, we're building a cancer-focused hospital. We got the cancer center renewed. We have really built a strong focus on advancing the science of cancer in Latinos with wonderful colleagues such as Dr. Emily Ramirez. We've built a cancer service line, I think having a great impact. So why the move? Well,
Yeah.
the move, I think, is really about opportunity. I'm confident that the Mays Cancer Center is on a tremendous trajectory to achieve comprehensive status as an NCI cancer center, and know that they'll recruit a strong successor, and I'm going to be a resource to that successor. But the move, I think, was about opportunity. I visited and have had strong relationships with both the Wake Forest Baptist Comprehensive Cancer Center, the Legacy Center in Winston-Salem, as well having gone and visited as a visiting faculty to the Levine Cancer Institute back in 2018. Know Derek Ragavan well, many wonderful colleagues there, and been tremendously impressed by by the scale of the operation, the tremendous patient-centeredness, wonderful clinical trials, outreach to the community. So when this opportunity to try to bring together the integration of all of these elements, the Legacy Wake Forest Baptist Comprehensive Cancer Center, the tremendous Levine Cancer Institute and all of its regional sites, and the opportunities of Atrium Health, which is a very large health system, now merged with Advocate Aurora to become the 5th largest health system in the United States. Thought that the ability to have an impact was really tremendous. One, the opportunity to really be on the ground floor in building a culture and shared mission between two wonderful cancer centers and really make them function as one, and bring some of the experience I'd had from Mayo Clinic on what a multi-campus but integrated NCI Comprehensive Cancer Center can look like.
So what's really interesting is this is clearly of great interest to people who read the cancer letter, because I looked at the end of last year's numbers, and the stories that we wrote about Wake Forest and this merger were #1 squarely. So there's something here that is extraordinarily important, because here you have two very different cultures. One of them is Levine, which is visionary and different, and it's Derek's creative genius that created that. And the other is a very sort of traditional comprehensive cancer center. They merge them. They do fit or don't fit. They obviously didn't fit together in an easy and harmonious way. So they need somebody visionary who can bring this together. That's why you're here, right? So how are you going to do this? What do you see? Or am I wrong? Actually, I could be wrong in the characterization here.
So first, I think some of the controversy at first really was, what was the plan going to be? And over this past year, I think there has been a lot of self-reflection, discussion, planning, and work toward integration, led by William Blackstock, who's been the interim director at Wake Forest, working hand in glove with Derek, really around, how do these two things kind of integrate? And I think a lot of progress has been made. That's been validated by the external advisory board, now led by Dr. Ed Chu, the director at Einstein. So a lot of progress. From my end, as I visited with folks from both campuses, I think the core things that matter really are the same. These are strong teams of individuals who care deeply about making a difference in cancer, who care about great patient care, who care about wonderful clinical trials, who care about how we advance the science of cancer. Now, I think one of the things that's really special about this opportunity is that there are some things that I think really fit in a very strong complementary way. So, for example, Wake Forest has had tremendous investigators in cancer prevention and control, with prevention and screening, with the MCORE research base, and really view that the extension into Charlotte and into the Atrium Health system in cancer prevention, screening, drug development are huge opportunities. Mm-hmm. It is a cultural lift, bringing together two organizations. What has been going on in parallel, which helps tremendously, is that really the organization has been integrating in parallel. So first, there's going to be an additional campus of the Wake Forest Medical School in Charlotte as an additional academic hub. There is really integration along all the key areas in healthcare, with cancer being clearly what I have been tasked with integrating and bringing together as one team, but in others, whether it be cardiology or musculoskeletal or others. Additionally, there is a new dean that is joining this month from Duke, Ebony Boulware, who was the PI of the Duke CTSI, who focuses on chronic disease and health disparities. Mm-hmm. But she's going to be a tremendous colleague and close partner. Obviously, one of my roles is as her vice dean for cancer programs for the School of Medicine. So really working hand in glove with her as to how we integrate these efforts kind of, across really that whole region. We've worked as a cancer center. They've done efforts to really reflect on what is the catchment area of this new integrated unified cancer center. And it's been adjusted. It's an area of 30 counties, including both the Winston-Salem and Charlotte area, almost 4.8 million individuals, representing 27,000 new cancer cases, 43% of which are rural, 36% of which are minority, with overrepresentations for African American patients, 10% Hispanic patients, and some very historic issues of health disparities, a lot of tobacco-related mortality and increases in mortality from lung cancer and others. It certainly is part of the region that very much was a central tobacco growing region, with Winston-Salem really having been a historic base of those sorts of activities. So I think although it clearly created a lot of interest and in some ways angst and kind of a challenging year as things kind of progress through this part, I think it has both tremendous trajectory because of the leadership that's kind of occurred over this past year, and certainly I feel that I've been kind of empowered to really take this on to make it truly a multi-campus NCI comprehensive cancer center that I hope preserves both the spirit of what it means to be an NCI comprehensive cancer center, but also does preserve the spirit and some of the ingenuity that Derek Ragavan brought to Levine Cancer Institute as well.
Mm-hmm, mm-hmm. Well, you've got till January 31st, 2025, with the possibilities of extension if the EAB loves what you're doing, and if NCI loves what you're doing. You kind of need to impress both of them. What have the communications been so far with NCI and with EAB on this? Because that's
so the communications have been very favorable.
Mm-hmm.
The center, both years 4 and 5 of the grant are kind of pending, depending upon progress toward integration, as well as really the support of the EAB and the NCI, that the center is making great progress, that it really is functioning as one center, that it's really making an impact. I think those conversations are favorable. I'm strongly hopeful that we will be successful in restoration of that funding for years 4 and 5 to give us really the full 5-year arc to both deepen our impact, to be able to continue to modify our strategic plan to make the full use of the opportunity that we have to further flesh out our team and really make use of the opportunity. You know, one of those key opportunities, you know, how is this cancer center going to be unique? This unified cancer center takes advantage of a concept really across our system, which is the academic learning health system. You know, how does one kind of go bench to system and system to bench? You know, how do you take observations and really apply them at scale? And then on the flip side, how do you learn from things at scale, from data in large populations, from complex community care tied to academic hubs, and then be able to apply that back in the questions that are being asked, whether they be in cancer biology, in health disparities, in prevention and screening, or others. You know, so I'm hopeful we will have that full 5-year arc to really develop as a unified enterprise cancer center over this time, and then hopefully successfully renew the NCI Comprehensive Cancer Center.
That seems to be a possibility, you would think, because if your EAB goes to bat and make sure that that happens for you, then NCI would probably say yes.
Certainly the trajectory, and this is both with my direct conversations with Henry Ciolino, the leader of the Cancer Center program, as well as our EAB, that all of that looks very favorable. Clearly, both the progress over the last year, a strong EAB report from our EAB last fall, the ability to have recruited a permanent director and having me jump in and start kind of with both feet right away in 2023, all strong signs of progress.
Yeah. What about the catchment area? Let's return to that for a moment, because that's you mentioned it's 30 counties now. What was it before for each of these, and how did the catchment area situation change, and when also?
So the catchment area has evolved over this past year. I can't speak with great authority as to exactly what it looked like before, but it has been narrowed. I believe it was 38 counties at the time of their prior renewal. It certainly has become more concentrated to that region in North Carolina and northern South Carolina. I think there had been some further regions in Virginia that had been prior part of the catchment area has been tightened. A bit really reflecting the opportunity with really setting a threshold of where 91% of new cancer cases are coming now for the combined system, as well as the counties really where they're having their both an impact, as well as the patients that they serve. Levine, not having pursued NCI designation in and of itself, did not have a defined kind of a NCI type catchment area, okay? But they were very active in their community in a range of ways, including things even such as lung cancer screening. One very innovative piece that Dr. Ragavan and colleagues had developed is something called the lung bus, where they had a bus that can do low dose CT screening for lung cancer that goes in various regions, including, I believe, to the Catawba Nation, where they significantly increased the rates of lung cancer screening with that nation. So some really innovative things that they had done, and again, over this past year, they have been weaving again to create really one COE type effort across the Unified Enterprise Cancer Center.
Okay, so basically, you've shrunk the number of counties because Levine really was their idea of catchment area was fluid. That's basically
In terms of counties, yes. In terms of number of patients, an increase.
Yeah.
Because of really the population density around Charlotte, and reflective, what's the opportunity is of the combined cancer center. Together as a center, it has over 25 venues of care, over 350 cancer care providers, does over 400 stem cell and CAR T therapies a year, over 20,000 new cancer cases, almost 1,000 treatment accruals, so a bit more concentrated, but highly impactful.
Would this be, I know this may be, you may not even have the answer to this, but is this the largest cancer center, or one of the largest in the United States now?
In terms of where it would rank, that I don't have the data for comparison, but I would think in terms of scale and impact, certainly would be one of the largest, without question, in terms of number of sites, providers, new cancer cases, and certainly most important from my end, I really hope in terms of impact. I'm hopeful that, again, we will be able to pilot things on a small scale, then really be able to test them at a much larger scale across the system, and then really be able to extend them further out into both the system and really across the U.S. One additional piece of this, and it's a piece that is evolving, is the merger of Atrium Health with Advocate Aurora. That is a recent piece. The merger completed its process just a couple of weeks ago in December, and what the exact plan will evolve in cancer is something that is evolving, and certainly I, as the cancer center director, will be intimately involved with that. We've been visiting with Dr. Jim Weiss, who is the service line leader for Advocate Aurora. That is a very significant system in Illinois and Wisconsin, again, caring for almost a little over 20,000 cancer cases between Wisconsin and Illinois. We envision many short-term opportunities as it relates to data, opportunities in terms of efforts in health disparities, potentially decentralized clinical trials, and other pieces. So that part evolving, but the opportunities, you can imagine, is enormous. Even the data and opportunity to learn from over 40,000 new cancer cases per year is really very significant.
So basically, that may very well be the largest with the merger. What's the timeline for your involvement in that merger? Does it even exist yet? Because I just see this as something so monumental. That's like you're in the middle of one monumental task, and here's another one looming.
That is more incremental. Yeah. With the merger process, again, they have worked really on more kind of front office operations, but already are ongoing in terms of supply chain, or you can imagine from our end, opportunities in terms of chemotherapy, drug acquisition, or shared contracts. So there's more of those pieces to start. The granularity of what that's going to look like in a service line like cancer is evolving, but the opportunities are many. So my first task, of course, is very North Carolina focused, but clearly view that over time as a huge additional opportunity.
Wow. To quote Joe Simone, when you've seen one cancer center, you've seen one cancer center. I quote Joe Simone often on this, probably too often, but no, not really. So, well, this is like nothing else. This is kind of just huge and different, and must be. How would you summarize it? How is this different from all the other centers?
Well, you are right that every center, having had a chance to visit many, either as a site visitor on an EAB or as a visitor or a friend, is different. I think the very unique piece with this is truly, a strong academic cancer center with 2 hubs in Winston-Salem and Levine, with many regional sites, but tied to a very large integrated academic health system that opens up a tremendous amount of opportunities. We realize that making a difference in cancer is both about what we do for cancer patients, but everything what we do really for the general public to help prevent or screen cancer to begin with, or how we really care for the large number of growing cancer survivors, and all of the health issues that they really have with them. So I think that's really what's going to be one of the unique things about this center is both that core of cancer expertise, cancer biology, cancer prevention and screening, and population science research, but the ability to both learn from the system, but also to extend opportunities across the system. I'll use an example. They had a very successful trial ongoing, called Empath, that was a shared decision-making colon cancer screening trial that they have been doing at Wake Forest for a number of years, with tens of thousands of patients enrolled, that again hoping to increase uptake of colonoscopy and other cancer screening, and again the ability to extend innovative approaches to increase screening or the effectiveness of screening across first Atrium Health, but then really across even a broader system is really tremendous.
Well, can we talk about disparities separately now? Because I kind of wonder, this is a huge interest of yours. You're involved in an initiative with Rob Wynn on some of this. What can you do with disparities that you haven't done with disparities that's not being done? How can you change things?
So disparities are something that remain central in my focus, and something we really want to make a difference about. And indeed, my good friend Rob Wynn and I have been chatting about some of the opportunities being our centers much closer to one another over on the East, on things that we can really do together in a range of ways. I think the opportunities here are significant. One, the populations are different, and learning about both the populations and how to really meet and impact the communities, both of Native American nations as well as a large number of African American patients, is different and complementary in my experience in San Antonio, but the core issues are the same. The issues of rural health disparities, which can be very significant. As a center, I think that there are several key opportunities. So one, there's really tremendous population science that has existed through the NCORE research base in the Cancer Prevention and Control program in Winston-Salem. And as we speak, there are efforts really to try to extend those efforts into Charlotte and into other regions, both in our catchment area and beyond. Innovative approaches in terms of dealing with populations, expanding prevention and screening, and others. Two, the opportunity really of decentralized clinical trials. One of my areas of passion is trying to have our clinical trials be reflective of our population. And the limiters to those have been many, from over complexity of trials, difficulties and burden in terms of travel for participation in trials, issues of trust. So how can we leverage the geographic extent of the system to be able to deliver trials at greater scale with greater, less impact from geography for people having to travel as an enormous possibility. A tremendous ability in terms of tobacco cessation. Unfortunately, having kids in their 20s, I see that there's a resurgence of both tobacco as well as e-cigarettes, vaping, and other things that again are going to come back to haunt us. That some of the progress we've made historically has been lost a little bit in somewhat of the panache of smoking kind of returning a bit for younger individuals. That's been a historic area of strong focus with a tobacco cessation center of excellence that has existed in Winston-Salem, and how we really extend that both across our catchment area, but really to try to decrease some of the health disparities in the region. Certainly tobacco and others have things that have helped, that has really hit underrepresented communities in a disproportionate way. So many opportunities, but I think both the scale, the geographic spread, as well as the parallel efforts of the system will go a long way. I mentioned earlier partnering with the new Dean Ebony Bulwer, that again, a strong emphasis for the system is really population science, how we really make a difference in populations in cancer, but also in the metabolic syndrome, in diabetes and chronic diseases. I view that these things really will work very much in parallel. At the system, there's an NIH-funded aging center, a CTSI, and other natural partners that will really be, I think, very strong partners in our battle against cancer.
Our readers obviously would love to know what are you going to beef up? Where will you be hiring?
So a lot of planned growth. So one, clearly first in population science, and in cancer prevention and control. It's already an area of strength. We view that really that and informatics are strong opportunities, both in terms of the extension into Charlotte, but really to leverage the opportunities of the system. Two, we've had strong drug development, but really looking to add additional scientific shared resources and bring in additional investigators to truly have the full pipeline from concept in medicinal chemistry through the strong clinical trial mechanisms that we have both in Winston-Salem, in Charlotte, as well as at our regional sites, as kind of critical pieces. There's a couple of key recruitments that we have planned ongoing, including our AD of community outreach and engagement. That's a key search that we're going to be launching. Additionally, as you might imagine, this is a large, complex organization that we're building. So again, looking to bring in, there's not been historically a deputy director at the Wake Forest Baptist Comprehensive Cancer Center. I do think as the enterprise, a unified cancer center, one or more deputy directors may be appropriate. Potentially recruiting a key partner to be based in Charlotte to work hand in glove with me. I will be practicing at both locations, but will be kind of physically based in Winston-Salem. So a lot of key areas of recruitment. Additionally, we're going to be growing further as we refine our strategic plan, in our core areas of discovery science, in neuro-oncology, which is a strong area of strength with the tremendous efforts ongoing in CNS tumors, in cancer genetics and metabolism, one of our core programs, as well as the program that we have that we partner with colleagues at Virginia Tech, which is our signaling and biotechnology program. So part of my role as Cancer Center Director is seeing as we grow, as we perhaps refresh or evolve the strategic plan that had been in place at the Cancer Center to make full use of the opportunity of both the expanded geography, patients, faculty, and resources, both in Charlotte and across the system. What are the key scientific areas that we have the greatest opportunity to make an impact, and how do we further grow the faculty and our Cancer Center members to really make use of that opportunity.
So you'll be hiring a whole lot of people, is what I'm hearing.
Yes. Clearly, I enjoy building, and this is a great building opportunity.
So they must have given you a nice dowry.
They've given me a great support, both in terms of, true core research funds, but really also in terms of being able to leverage the practice hand in glove with our efforts. I wear more than one hat, but one of them as president of the Enterprise Cancer Service Line, where truly we can, look at clinical revenue, hand in glove with our efforts in research and education to really make our goals possible.
Did I hear that you'll be actually practicing medicine, seeing patients in addition to all this?
Yes. So I throughout my career, it'll be modest, but it will be, going to do a half-day clinic in each spot, in each of the two main hubs, once a week. It's a great way to connect with the faculty. I very much enjoy my own personal research with patients with myeloproliferative neoplasms and clinical trials, and have some really strong colleagues in both areas. So it's always something I want to be involved with.
That's fascinating. So you basically get more than 24 hours to a day, right? Give you some extra time. What about what keeps you up at nights? What worries you the most about this job right now?
Well, I think like any job with this, one never underestimates the challenges that relate to coming together as a culture, and timing. But I'm confident. I think we're going to have the time, and we have the support. I think both of the institutional leadership, as well as really the faculty and the staff, for us to achieve what we hope to achieve. I've sensed great excitement from the NCI and our EAB and really other members across the cancer community for the opportunity. So although it's going to be work, I'm confident we're going to be successful.
Is that Dr. Raghavan is retiring? Is that what's happening, or?
That is correct. Derek is retiring on January 14th, and really leaves an unbelievable legacy, I think, of really a very unique concept and model, but also, I really have been able to see firsthand a legacy of tremendous mentorship, of a deep caring for his faculty, of really deep patient-centeredness, and really, well-supported holistic care, very well-articulated supportive care systems for patients, great navigation, a great engagement with the community. He really leads a tremendous legacy as really a stellar leader in cancer.
Totally visionary. What about Dr. Blackstock? Is he staying, or?
Yes. So Dr. Blackstock, again, long-standing both cancer researcher and investigator. He's the chair of radiation oncology and will remain a critical partner and friend in this endeavor in many ways. He's really done a tremendous job, during what you might imagine was a challenging year, with the reconstitution of the EAB, with really working along with Dr. Raghavan in terms of integration, of really, keeping folks, in the team. There's always some stress during periods of interim leadership, and really had done that with tremendous grace. Did that very, very well, really set it up well that, I could come in as a new recruit, with confidence on the strength of where I was coming.
What about Dr. Pasha? Is he staying, going?
So Dr. Pasha is a good friend. He's been a strong collaborator for the Mays Cancer Center, and someone that I have tremendous respect for. He's still an active investigator, at the Cancer Center. Still a very active member of the programs. His own research in his company focusing on radio frequency, kind of therapeutics, is very innovative, and he's still very excited about his science, and I'm very excited for him and what his company and what his really vision of a different kind of a different modality for treating cancer, where that's going to go.
So you're staying.
Yes.
Oh, cool. So is there anything we have missed? Anything you'd like to touch upon? Anything I neglected to ask?
No, I think that was pretty comprehensive.
Well, thank you so much, and I can't wait to continue to follow what's happening. It's going to be a very interesting story.
Wonderful. Well, no, thank you so much for giving me this opportunity to share a little bit about the story. It's an exciting one, and again, look forward to updating you on what I think what will be the very special impact of this cancer center.
Oh, it certainly looks that way.